cozy in here.
Isn't it nice?
IKEA?
Yeah. Welcome back to another episode of the New School OBGYN podcast. We have back with us Dr. Olga Valieva.
Hi. It's been a while.
It's been a while.
Yeah, sorry about that.
Welcome to our new podcasting digs. We're currently at my office where we put this together.
Yeah, and I'm a little jealous of your digs, I'm not going to lie.
It's the first time she's seen it.
Yeah, mine's so sterile.
Thanks all for tuning in. We also grabbed Dr. Olga from her surgery, which she's about to do. We're talking about endometriosis today.
Yes.
And the myths, and she's about to do a potential diagnostic surgery for endometriosis. So, thanks for stopping by.
That's timely.
So everyone, give it a like because she's coming in on her day off because Wednesday's our usual day off.
Don't like it for that.
Like the video.
Dislike it because you all should have a good work-life balance and not work on your days off.
We need to work on our work-life balance. That is, but she's taking care of her patients and doing a joint surgery with one of the other surgeons. So, yes, today we're talking about endometriosis myths. And if you haven't seen our hysterectomy myth video, we'll link that here. But we're going to start on a journey of talking about endometriosis because, and it's a journey because a lot of times it's a journey for our patients, for the just getting to the office, getting it worked up, getting it diagnosed, getting it treated. And so we're going to take many videos to discuss endometriosis because it can be quite impactful.
Yep, and there's a lot of things to cover.
A lot of things to cover.
Yeah.
It's a topic with a lot of emotions attached to it too.
And opinions, I'll say.
And opinions, expert opinions, personal opinions. Some things work great for some people, some things don't work great for other people. And so as providers, we often talk in kind of a general sense, try to encompass most patients when talking about certain things. But if you have a question, comment, leave it below, but let's keep everything very nice.
Yes.
And so we're going to work our way through different myths here. First, let's start with, it's just bad cramps. Endometriosis is just bad cramps. And I think that's a myth for a number of different ways. And I think the main point here is if you're having painful periods, painful time before your periods, go get checked out.
Yes.
And if you're not getting the answers you want, get a second opinion.
Yes. Yes.
And that there's nothing wrong with that.
I will say, I mean, as far as myths go in general, and I'm not trying to be sexist here, but as a man, I'm sure you never got this, oh, like, suck it up is just part of being a woman, right? Normal period pain is not normal. It's your body's way of telling you something's going on, right? So, yes, cramping is common, but for it to be debilitating and for you to have to not go to school or not go to work or whatever, have to guzzle like, a whole bottle of ibuprofen every single cycle, that's not normal. So when you experience that kind of pain and it's either you dismiss it, you're not dismissed, but you're just like, okay, it's fine, I'll just, it's just a couple of days, right? Or it gets dismissed as like, oh, this is just something that women go through. Don't just assume that, like, get it checked out, make sure it could just be, yes, there is a condition of primary dysmenorrhea. People just have really painful periods, and it's not necessarily endo, but it doesn't mean...
Dysmenorrhea meaning...
Sorry,
our
painful
term
periods,
for
yes.
painful periods, yeah.
But that doesn't mean you shouldn't look into it and get it checked out to see if there is something else contributing to that pain, right? Like, don't just assume, well, this is my lot in life, and I just have to live this way. And I don't know if you're finding that a lot of younger patients, I think, are more willing to explore this versus some of the...
prior generations.
Correct. Yeah, like maybe people of my I'm not old. People in their like 40s, 50s, 60s are like, oh, I just thought this was normal, right? So I hear that more often as like, oh, I just thought that was part of life, right? And I don't know, do you have a different experience of this?
No, I would agree.
I feel like more younger women are coming forward and speaking up and advocating for themselves, and I
think the positives of social media?
Yes, definitely. I was just going to say, I think that's part because of social media and just people being more outspoken about it and making it be more acceptable to discuss these kinds of things and not as taboo. It's like, ooh, she's on her period, let's not talk about it.
Right.
Yeah.
And it can be very different for every person.
Yeah. And another thing too, Eric and I were talking about this earlier, not everybody with endo has bad cramps, right? Not everybody has any there are people that have zero pain with their menstrual cycles or just have very mild, like a cramp here and there, and they have horrible endo, right? So I guess it's both ways. Just because it's bad cramps doesn't mean it's just bad cramps. It could be endo, and sometimes you can have a ton of endo and not have any cramps either. So if you have terrible periods, please go get it checked out. Don't dismiss it as normal.
We'll discuss this a little more in a bit, but just statistically wise, I think it's hard to completely appreciate how many people actually have endometriosis. Because maybe someone gets checked out for it in their teenage years, and they might develop it later on in their life. Or someone puts up with it and never gets help, never seeks help, and so you don't know that person as far as statistics go. But 1 in 10 is thought to have potential endometriosis, 1 in 10 women of reproductive age. And there can be almost a 10-year delay from symptom onset to diagnosis, whether surgically, medically, because I think of this whole myth number 1, just putting up with something because you thought it was just part of being a woman. And so we encourage patients. I always encourage mine. I know you encourage yours not to think this way. Get checked out, seek medical attention, seek second opinions, because yes, we have ways to help. And it's not just bad cramps. There might be a different diagnosis too.
Right. It might not just be endo, but either way, look into it. Don't just live with it.
Don't be so set on the diagnosis of endo, but there are certainly a list of possibilities it could be, all of which likely have a treatment. Anything else, Chad? I like that.
I think that's it. Yeah.
Okay, myth number 2. Something I see here and there. It will cause infertility, and it certainly can. And so it certainly can impact infertility for some, and not all, but any thoughts on how that can impact infertility?
Yeah, I mean, there's a couple of reasons, and I wonder if some of our REI colleagues might have different opinions on this too. So a couple of mechanisms. One is just endometriosis is an inflammatory condition, so causing inflammation within your pelvis, I don't have words today, might impact the release of the egg, and then the egg being transferred into the fallopian tubes and the fallopian tube function itself. Or there could be scarring from the inflammation either on the fallopian, at any part of the fallopian tube. Sometimes the ovaries will have implants, endometriosis implants themselves, and just not function normally. So there's a lot of different reasons. So those are kind of the more common reasons, and probably...
Again, I don't think it's perfectly known.
No,
a lot of that is with endometriosis. I mean, more smart people who are working on it, as we speak, to find out different things about endo, but and how it affects infertility and all of these other things. But yes, tubes, and you can test this out with different tests, like what's called an HSG or hysterosalpingogram. X-ray test where they infuse dye through the tubes. Is probably the best way to find out if the tubes are being infected by endometriosis. And I think theoretically, I mean, this may be getting beyond the scope of this podcast, this episode. But I mean, someone with a diagnosis of endo, now unfortunately insurance doesn't perfectly cover these tests, but the price would range here in the US, potentially $500 to $1,000 for this test, to check to see if the tubes are open. And could someone do this at, every few year interval, potentially? Maybe. But yeah, tubes are one big thing when it comes to endometriosis, and that's more rare. It's stage 3 or 4 endo that's causing these issues with the tubes.
The more advanced stages. Should we talk about the stages? The more advanced stages.
We can touch on it. There's stages to endometriosis.
Yeah, the more advanced and the more, I guess, spread and diffuse it is, and the more scarring there is, the more likely you are to have infertility. But it doesn't mean that you will have infertility. It's just the worse the endo, the worse the fertility journey.
With the tubes, yeah. And I've had a few cases recently where the tubes were significantly impacted, and if they are, unfortunately, tubes just don't heal.
No.
And so it's just leaves somebody in a tough situation where
finicky little guys.
IVF might be the only way to get pregnant for those. If the tubes are affected, or if it's inflammation, like you said. I mean, inflammation in that area leads to difficulties with the egg release, fertilization, that's such. I mean, that's how the Paragard IUD works, is causing some inflammation. And so.
Yeah, and oftentimes even people going through IVF, sometimes it's just difficult to stimulate the eggs too, or you don't get as many eggs out of the ovaries just because they're not, you know, they're diseased. So yeah. But yes, just because you have endo does not mean you can't get pregnant. It's just
right. It's not.
It might be trickier.
It's not a doomed diagnosis.
Yes.
It's something you're gonna have to watch going forward and maybe treat or suppress until you are at the point where you want.
Yeah. That's a great point. So oftentimes, if we do find it early on, many people are not sure if they want to have children in the future, but either way, just to preserve the aspect of fertility down the road, it is important to, when you first diagnose it, especially in those that are interested in childbearing, to suppress it as much as possible, just to give them an opportunity to have that potential in the future.
Right.
Yeah.
It's really hard not to go into like the full like aspect of like talking about the treatments. It's like, because some people are, you know, like, oh, well, why did they just give me birth control pills for this? And it's kind of along that same idea. Is endometriosis is hormonally activated often, and so often we combat that with hormones, which would be things like birth control pills, and can do it in certain ways to suppress it versus, you know, there's certain ways being continuous, you know, extended cycle or just regular cycle birth control pills, but getting down the rabbit hole and beyond the scope of no, that was my fault.
I started calling it hibernating the endo because that's what we're doing with hormones. So okay.
Nice. Quick facts about that. You know, because they think, again, it's hard to know because there's so many factors that go into infertility also, but potentially 30 to 50% of people with endo may experience infertility. That's a high number, but again, I don't think that's all because of the endo, because there's so many other factors to infertility.
Sure. And sometimes there could be endo, but the infertility is secondary to something different. So it's just it's a messy topic.
It is.
Sorry.
But
that kind of brings us into our next myth.
Perfect transition.
That pregnancy is a cure for endometriosis. Yeah. It's not. It's not.
It's not a cure, but again, it's a hormonal shift that is friendly to the symptoms and inflammation of endometriosis.
Yes. Yes.
The hormones in pregnancy and the consistency of those hormones. Endo usually is activated through the cyclic nature of the hormones, and so there isn't that same cyclic nature of the hormones during pregnancy, and so it's mainly consistent hormones that are suppressing the endometriosis.
Yep. And then that also leads into then lactation as well. So everything's kind of dormant, but it doesn't erase it from existence. It just kind of keeps it symptom-free for a while, but then when you go back to your regular cycles, then everything kind of wakes back up. So hibernation yet again.
Hibernation is good.
I did see an article, I don't know if you read, maybe 2 articles about off-label use of HCG. Do you remember when there was this big HCG fad when people were injecting themselves with HCG for weight loss or whatever?
Okay.
Yeah. In the same vein, they were using HCG to see if they could suppress endometriosis. It was just like random case-controlled studies. It was actually pretty, I mean, for the small number, I mentioned it to one patient, she took me up on it, and I was like, oh, that's interesting. I don't know, off-label, I have to be very honest about it. Like, it's not a treatment method, but, you know. It's,
again, kind of goes along the same hormonal pathway of, like, trying to suppress it. Yes, what was I going to say about that, too? I mean, you hear stories, too, about people really, like, maybe physicians saying, you know, you have endometriosis, you should get pregnant right away.
Yeah, don't. I mean, that's
kind of goes to the previous myth, like, generally, it doesn't, you know, keep an eye on it, and but
I wonder if part of that is also because of the issues with fertility. Their concern is don't let it get too bad, like get pregnant earlier so that it doesn't cause infertility, but that shouldn't be the reason why somebody chooses to become pregnant, obviously. I wouldn't change your fertility plans based on a diagnosis of endometriosis, like, oh, now the clock is ticking even more than it was before, you know, so it's, don't. Yeah, that's not a real reason.
I mean, most people have very early disease, and so to kind of say, oh, you should get pregnant, you know, but, you know, there are some people with more advanced disease, and the discussion might be a little different, but, you know, you should never feel pressured, your fertility and childbearing pressured because of the diagnosis.
That happens. I wonder if it's a self-pressure or, like, provider-inflicted pressure.
Both. And I think it can be both of, you know, coming from providers that maybe don't deal with endo too much, and also, you know, information you see online.
Yeah.
Ready for next?
Sure.
This is a good one, because I often get patients saying, I had a hysterectomy for my endometriosis. And so myth number 4, it is cured by hysterectomy. Endometriosis is cured by hysterectomy. I'll let you go first on that and initial thoughts.
It significantly improves the symptoms of endometriosis. I mean, the definitive treatment would be to do a hysterectomy with oophorectomy, meaning having your ovaries removed, but it still doesn't fix everything because endometriosis, and I think this will go into our next myth, it can be present more than just within the uterus and ovaries. So yes, removing the uterus and the source of endo, if you will, does improve symptoms for, what is it, like 80-90% of women, but not for everybody, right? And then people will often develop chronic pain because of endometriosis, and that can linger even after you resect all of the endometriosis. So yes, it's a treatment option, but it's not a curative option.
Yeah.
Right? Did I say that right?
No, yeah.
Okay.
I think often too, it can be that the uterus is still the main source of the pain, whether that's adenomyosis, which is basically, I just did a video on adenomyosis too. But adenomyosis is basically like endometriosis in the uterine muscle.
Pretty much.
And I think it's more common than people think. And so often that pain discomfort can be from the adenomyosis or the uterus or primary dysmenorrhea like you talked about. So removing that source can significantly improve the symptoms, and maybe the endometriosis is kind of like a coincidence that it's there. I don't know. But yes.
It does improve it.
Right. If someone still has their ovaries and they have a hysterectomy, they can still have endometriosis. There's a couple different theories on how endometriosis actually starts and spreads. The thought is it can be retrograde, and I'm going too far into things, but thought it could be like retrograde menstruation, meaning the menstruation, instead of coming out vaginally, is coming through the tubes, or those cells that are the endometrial cells that are supposed to cause your period. You know, they come out of the tubes and into your pelvis. I think that's one theory, but but there's definitely valid
like
points to say
sources,
like, or like endometriosis like is initially implanted during our development as a
like
fetus.
embryogenesis,
And like these little endometrial cells are just kind of seeded through that, and so.
Or C-section seeding. Don't forget about that
is
one.
also
Yeah,
one,
that's
a big
legit.
one.
Yeah.
And so yes, not always a hysterectomy is a complete cure.
Correct.
But it does help symptoms for a lot of people, and I think that's the main point to say about that.
And often, I could be wrong, but often if women are done with childbearing, that's such an old word, childbearing.
I know, I hate saying it, but
are
I keep
done
saying
using
it.
their uterus to reproduce,
Yes,
I guess.
perfect.
And they're open to a hysterectomy. Oftentimes it is the next step to treatment, but it doesn't have to be. And again, symptomatic endometriosis, not everybody needs to have a hysterectomy.
Right.
Yeah.
Yeah. Good topic.
Okay.
Myth 5. Endometriosis only affects the reproductive organs. And it certainly can affect a lot of different organs. It certainly can spread to different areas. I think most commonly, what I would say symptoms in other would probably be either the GI symptoms that come with endometriosis, people who are diagnosed with IBS, and then all of a sudden
it's endo instead.
They found out it's endo, because a lot of IBS is like an inflammatory kind of response of the bowels, and that's what endometriosis is, and everything in that area touches each other. And so if one thing's inflamed, that inflammation leaks over, causes maybe symptoms in a different organ. So you don't actually have to have, actually another point too, is you don't actually have to have the endometriosis on your bowels to cause bowel symptoms.
Yes.
It just in proximity certainly can.
But yeah, but it, like you're saying, it does spread to other parts of our body. So oftentimes, aside from the pelvis, which is where it's mostly found, and I'm guessing you do this too, I always look around the entire abdomen, like look at the diaphragm, look at all the like cul-de-sacs, if you will, just to make sure it's not there. Am I going to go poking at a liver? No, but I'll take pictures of it. But it can spread outside of the abdomen as well. I mean, they found it in brains, eyes, skin.
If somebody
like
has a really weird menstrual-related symptom with some other organ in the body, like during menstruation, they like cough up blood. You probably want to get an MRI or something like that.
My favorite one is I had one patient who had it in her belly button, and she would bleed out of her belly button every menstrual cycle. So she was like, "Well, this is really annoying." I'm like, yeah.
So it can be kind of crazy. It can implant in many different areas, not just the bowels, the bladder, the sometimes people get weird nerve sensations down their legs because the proximity or potential endometriosis in that area.
And pelvic muscles too. Sometimes we just because we don't see it in the muscles doesn't mean it's not in the muscles. So I think that kind of goes back to the earlier myth about hysterectomy curing everything. We can remove the visible endo, but then there's endo behind the scenes, retroperiton behind the perineum, like deeper in the tissues behind the curtain, that we can't see, but it's still causing pain and could be cyclical or constant. And often tell patients if there's what we call negative findings, like if we go look and we don't see it, that doesn't mean it's not there. We just didn't see it today or now, right? So it's not just in the uterus, ovaries, fallopian tubes. Yeah.
Or even if it is, I mean, again, the proximity effect. Where if we're talking about pelvic floor, like the exact, if someone, let's say, is getting a hysterectomy because of their symptoms and they notice like maybe they're not all the way better, they're still having painful sex, things like that, it's probably because the endo's been really inflaming the pelvic floor for so many years that now there's an ongoing pelvic floor problem, and so that needs to be addressed before someone gets really good symptom relief. So, yes, not only the uterus or reproductive organs, but other potential things. I think this next one's a quick one, saying it's uncommon, because we already talked about that, the fact that, there could be 1 in 10 women with endometriosis. That means potentially like almost 200 million people. And, average time to diagnosis can be 7 to 10 years. So anything additional to add on that? It's just uncommon.
I mean, it's hard to know how common, like we were talking about earlier, just because we don't go looking for it or people don't seek treatment for it, we just don't know what the true incidence and number of endometriosis is, right?
Maybe once we get rid of those barriers, people are coming in, seeing people that are versed in endometriosis care that actually get, streamlined diagnosis, not waiting for years or decades, that will help us understand.
And give us better numbers for sure.
Numbers.
Yeah. And oftentimes I'm going to delve into myth number 7. We don't always need surgery it's the gold standard to diagnose endo, but oftentimes we kind of symptom-wise, if it quacks like a duck, and looks like a duck, it isn't, right? So we treat it without necessarily doing surgery. I mean, yes, the surgery is a definitive tissue diagnosis, but we don't need to do surgery per se to treat it and diagnose it. So that kind of, it's presumptive diagnosis, and that I don't think gets an official title and officially goes on record and then gets.
Yeah, I think, myth 7.
Who's keeping track?
Myth 7 is it's diagnosed with surgery.
Is the CDC keeping tabs on? I don't know.
What's that?
Who keeps numbers on endo? Like, is there?
I think it's through studies, probably.
Yeah, I guess. I don't think
but a review
track
of
it
records.
Like measles or whatever. Sure.
There's no centralized tracking that I'm aware of.
We should have
and
one.
so you're saying, yes, traditionally the gold standard is to visualize it in surgery, which, again, surgery is a way you could potentially get relief through treatment with burning or removing of lesions that you see, but you're still probably going to likely do
I once had insurance deny me treatment because I didn't biopsy and send it to the pathologist, and I'm like, wow.
Insurance, another topic
I can see it.
Love.
Oh yeah, no, we're not going to delve into that. I'll get very angry.
So surgery, visualize it. Again, to that point of, you visualize it, but you're still going to want to treat it.
Sure.
Especially if it doesn't improve the symptoms. So you're probably going to be on hibernation, suppression, however you want to call it, treatment going forward but you don't have to be, I guess. So, but you can also visualize it with MRI. It was a good way. There's specialty centers where they're really good at visualizing it with ultrasound especially for you're not going to see superficial stage 1 necessarily endo with ultrasound, but if a lesion's digging into to the tissue or deep infiltrating,
or if it's a big cyst, then
for sure with an endometrioma, ultrasound's a perfect way to visualize it. But so there's some decent places they're actually really good at visualizing the ultrasound deep lesions.
And our imaging is getting so much better than even, oh my gosh, just within the 10 years.
Yeah.
We're picking up a lot more adenomyosis. I don't know if you've noticed that too on ultrasounds.
Already
It's like
has.
they're just, the imaging quality is getting so much better and we're seeing it and people are like, why is there so much adenoma? I think it's always been there. We just couldn't see it before, right? So as our technology gets better, I'm sure we're going to probably switch to this modality. Well, I don't know, maybe.
And I
we'll
think
probably
too,
use it more often.
the spotlight on improving women's health and not just chalking it up to painful periods or something like that. Like, it's kind of forcing the people to put that in the radiology report of the diagnosis. Like, it could be this.
Yeah. But yeah, so we don't often, I mean, not always, but we typically defer surgery as kind of last resort if we don't have to. I mean, do we love doing surgery? Absolutely. But is it necessary every single time for any bad menstrual cycle? No, like we want to try A, B, C, and D. And if everything fails, then we can go looking for it and see if, and we don't necessarily just want to look at it when we go in. We want to also resect it. If we find it's not, we're not rude and just like, oh, hey, it is. See you later. Good luck. So resection can improve your symptoms, but it's not the end of it, right? Like we still have to suppress it. So, if we can control your symptoms hormonally, medically, then fantastic. And if that doesn't work, then we go poking around. Or if you just want to know, that's, yeah.
How often would you say that if patient comes to you, symptoms classic for endometriosis, they'd rather start with a surgery diagnosis, how often would you say that you actually find endometriosis percentage-wise?
50% maybe?
I was going to say the exact same thing.
Yeah, it's like 50-50. Because oftentimes they just don't have anything visible.
And again, it doesn't mean that those symptoms aren't there or that it's in their head. It's like something is going on. Maybe, and endometriosis can look a number of different ways too, especially depending on where it is being hormonally wise, like where it is in the cycle and things like that.
Yeah.
And, you have your classic burn, cigarette burn lesions, or
I think it's gunpowder.
Gunpowder lesions.
What have you been reading?
I'm Jonesing. No, but
there's like the chocolate endometriosis, and there's the white endometriosis, and there's like
clear,
the Allen-Master's windows, and there's a lot of different ways it can look.
Yeah, that there's been like inflammation there in that area. But I tell my patients, like, even if we do the surgery and I don't visibly see anything, no matter how hard we look everywhere, like, I'm not going to take that diagnosis necessarily away.
Sure.
Well, we might focus a little bit more on other things. Myth 8.
Yeah. Oh.
Common one here.
Oh, yeah, that's a good one.
Endometriosis causes heavy bleeding. And my kind of old way of thinking about it probably was like, no, it doesn't. And I think that is true in a lot of ways, but there can be some potential complicating factors to that answer.
It, in and of itself, maybe doesn't, but we talked about earlier about adenomyosis being similar to endometriosis. So endo is more of a pain problem versus a bleeding problem, but if it turns, or if there is an adeno component or fibroids or whatever, it can coexist with other things. So not everybody with endo has heavy menstrual bleeding. Sometimes they just have terrible pain and like...
Two potential separate issues.
Right. Yeah, but it, in and of itself, I don't think... Well,
theoretically,
yeah.
Yeah, endometriosis should not cause heavy bleeding.
Right.
Because these lesions are outside of the uterus, where the bleeding comes from. It's not like that bleeding gets out back through the tubes. But, it causes inflammation, and we know that the uterus tends to bleed more if it's inflamed.
Yes.
And so...
But not like flooding.
I do keep my mind open because of that reason. But if someone's saying, yeah, grandma had a hysterectomy because she had endometriosis and causing heavy bleeding, she might have actually had like adenomyosis as the main diagnosis. But she probably got better from the hysterectomy, so does it technically matter? Not really, but just a common thing that we often hear is like, oh, I have heavy bleeding, I have endometriosis. You can have both.
It'd be interesting to go back and look at all the path reports where adeno and endo were found concomitantly just to see what the actual incidence of that is.
Right.
I'm wondering because I feel like it happens more times than not that it's just they're there together.
Right, and we call adenomyosis something different, but in reality it's probably actually very similar. It's just endometriosis in the uterine muscle. Definitely associations with adeno and endo. That is known.
Yes.
And it's definitely reasonable to think that.
Yeah.
But how often, the percentage-wise, I don't know off the top of my head.
Yeah, but don't assume that just because you have endo, to have endo, you need to have heavy bleeding. It's not.
Right.
It's not a prerequisite.
Right.
Yes, not part of a diagnosis.
that was a good little start.
Yeah. My gosh, there's so much to talk about. There's too
so much to talk about. So
like a whole day
in my mind,
conversation.
I was thinking at each topic, like, oh, do I go down this rabbit hole
so
and
many
this
of
rabbit
them.
hole? And so up in the upcoming videos, we're going to be talking about a lot of that.
Yeah.
And so anything else you want to add on this one?
No, I think go get it checked out. Speak up for yourselves. Advocate. Yeah, we're here to listen.
Yeah. And that's it for the episode, everyone.
Okay.
Thanks for tuning in. Again, like, share, follow. We appreciate all those. It helps keep us going. And we'll be back, hopefully not another 6 months. Hopefully sooner than that.
Sorry.
It's okay. Bye, everyone.
Bye.